Clostridioides difficile infection, spore-mediated transmission, diagnosis, and evidence-based management. Clostridioides difficile infection, CDI, accounts for greater than 500,000 hospitalizations and an estimated $1.5 billion in healthcare costs annually in the United States alone. The organism's obligate anaerobic spores resist routine disinfection, survive on surfaces for up to 5 months, and are the principal vehicle for patient-to-patient spread. Diagnosis hinges on a two-step algorithm that combines glutamate dehydrogenase, GDH, antigen screening with toxin PCR, achieving a pooled sensitivity of 96% and specificity of 94%. First-line therapy now favors oral fidaxomicin 200 mg Q12H for 10 days, with bezlotoxumab 10 mg per kilogram 4 as adjunctive therapy for patients at greater than or equal to 30% recurrence risk. Key points. Note: CDI incidence in U.S. acute care hospitals is 12.1 cases per 10,000 patient days. 2022 CDC NHSN data. Spores remain viable on stainless steel or plastic surfaces for a median of 154 days, range 90 to 10 days, despite routine cleaning with 70% ethanol. Prior exposure to clindamycin, fluoroquinolones, or cephalosporins confers a relative risk, RR, of 2.8, 95% CI 2.33.4 for CDI. Oral fidaxomicin 200 mg Q12H for 10 days yields a clinical cure rate of 92% versus 85% for vancomycin. Modify 2 trial, 2019, NNT equals 13. Recurrence after a first episode occurs in 20% of patients. After a second episode, recurrence rises to 40%, IDSA/SHEA 2021. Bezlotoxumab reduces 30-day recurrence from 27% to 16%, hazard ratio 0.58, NNT equals 9, in high-risk patients. Toxic megacolon complicates 2.5% of severe CDI cases and carries a 30-day mortality of 34%, Systematic Review, 2021. Fecal microbiota transplantation, FMT, achieves a 90% sustained cure after 1 infusion, randomized trial, 2020. Serum albumin less than 2.5 g/dl at presentation predicts 30-day mortality with an odds ratio of 3.2, multivariate analysis, 2022. Hand washing with soap and water removes spores more effectively than alcohol-based rubs, 99% versus 45% removal in laboratory study, 2020. Overview and epidemiology. Clostridioides difficile infection, ICD-10 code as 04.71, is defined as the presence of diarrhea, greater than or equal to 3 unformed stools in 24H, together with a positive laboratory test for toxigenic C. difficile or its toxins. Globally, CDI accounts for an estimated 2.8 million cases per year, with the highest burden in North America. Incidence is almost equal to 15 per 10,000 hospital admissions, and Europe, 48 per 100,000 population. In the United States, the 2022 CDC surveillance reported 462,000 hospitalizations and 29,300 deaths attributable to CDI, representing a case fatality rate of 6.3%. Age is the strongest non-modifiable risk factor. Patients greater than or equal to 65 years experience an incidence of 22.4 per 10,000 patient days versus 4.1 per 10,000 in those less than 45 years. RR equals 5.5. Sex distribution is roughly equal, male equals 49%, female equals 51%. Racial disparities persist. African American patients have a 1.4-fold higher hospitalization rate than Caucasians after adjustment for comorbidities, NANS 2021. Key points: broad-spectrum antibiotic exposure within 90 days, RR equals 2.8, 95% CI 2.33.4. Proton pump inhibitor, PPI, use, RR equals 1.5, 95% CI 1.31.8. Hospital stay greater than 5 days, RR equals 1.9, 95% CI 1.62.2. Prior CDI, RR equals 3.6, 95% CI 3.04.2. Pathophysiology. C. difficile is a gram-positive, spore-forming obligate anaerobe. The organism's genome encodes two major toxins, TCDA and TCDB, and a binary toxin, CDT, in 5% of hypervirulent strains, e.g., ribotype 027. Toxin B, TCDB, binds the frizzled-related protein 1, FZD1, receptor on colonic epithelial cells, triggering Rho-GT passe inactivation, actin depolymerization, and cell rounding. Downstream activation of the MAPK pathway leads to IL-8 and IL-1 beta release, recruiting neutrophils and amplifying mucosal inflammation. Spore formation is initiated during the stationary phase via the master regulator SPO0A. Phosphorylated SPO0A upregulates the sigma-K factor, driving expression of the CODA code operon that produces the protective exosporium. Spores are metabolically dormant, highly resistant to heat, survive 70 degrees Celsius for 30 minutes, desiccation, and oxidative stress. In vitro studies demonstrate that spores retain germination capacity after 180 days on hospital carpet when stored at 22 degrees Celsius and 45% relative humidity. Clinical presentation. The classic CDI presentation includes: atypical presentations occur in 22% of elderly, greater than 80Y, patients, who may manifest only with anorexia, 31%, or altered mental status, 27%. Immunocompromised hosts, e.g., solid organ transplant, frequently present with pseudomembranous colitis on colonoscopy without overt diarrhea, 15%. Key points: watery diarrhea, reported in 92% of cases, median 5 stools/24H. Abdominal cramping, present in 78%, median pain score equals 5 out of 10 on VAS. Fever greater than or equal to 38 degrees Celsius, documented in 45%, mean temperature equals 38.6 degrees Celsius. Leukocytosis, WBC greater than 15,000 cells/L, observed in 38%, median 17,200. Diagnosis. 1. Initial stool testing. Perform a two-step algorithm. A. GDH antigen, sensitivity equals 96%, specificity equals 86%, followed by B. Toxin PCR, expert C. difficile, sensitivity equals 94%, specificity equals 97%. A positive GDH plus positive PCR confirms CDI. A GDH positive/PCR negative result mandates repeat testing or culture. 2. Endoscopic confirmation. Flexible sigmoidoscopy with biopsy is reserved for patients with severe disease and negative stool assays. Pseudomembranes have a specificity of 95% for CDI. 3. Imaging. Abdominal CT with 4 contrast is the modality of choice for suspected toxic megacolon. Diagnostic yield equals 84%. Colonic dilation greater than or equal to 6 cm. Wall thickening greater than or equal to 4 mm. Test a reference range, sensitivity, specificity, GDH antigen, not applicable, 96%, 86%, toxin ABEIA, not applicable, 75%, 99%, PCR for TCDB gene, not applicable, 94%, 97%, serum creatinine, 0.61.2 mg/dl, albumin, 3.55.0 g/dl, CRP, less than 5 mg per liter. Key points: Atlas score, age, treatment, leukocyte count, albumin, serum creatinine, and previous CDI. Each component scores 0-2, total greater than or equal to 8 predicts 30-day mortality. Of 22%, validation cohort, 2021. Mayo Clinic CDI Severity Index assigns 1 point for WBC greater than 15,000, 1 point for creatinine greater than or equal to 1.5 times baseline, greater than or equal to 2 points equals severe disease, sensitivity equals 81%. Management and treatment. Drug EDOS, route, frequency, duration, mechanism, key trial, fidaxomicin, difficile, 200 mg, PO, Q12H, 10 days, inhibits sigma subunit of RNA polymerase, bactericidal against vegetative cells. Modify 2, 2019, cure 92% versus 85%, vancomycin, vancomycin, 125 mg, PO, Q6H, 10 days, cell wall synthesis inhibition, diala binding. Vancomycin versus metronidazole, 2015, cure 84% versus 71%. Metronidazole, Flagyl, 500 mg, PO, Q8H, 10 days, DNA strand breakage via nitroradical formation, metronidazole for mild-moderate CDI, 1996, cure 71%, monitoring. Check serum creatinine and liver enzymes, ALT/AST, on day 3 and day 7, adjust vancomycin dose if serum trough greater than 15 g/ml, risk of nephrotoxicity. Key points: hemodynamic stabilization, initiate isotonic crystalloid infusion, 30 ml per kilogram bolus, for hypotension, target MAP greater than or equal to 65 mm of mercury. Monitoring, hourly urine output, serum lactate every 4H, and daily CBC. Isolation, contact precautions with a private room, use a dedicated bathroom. Escalation to high-dose vancomycin, 500 mg POQ6H, for fulminant disease, IDSA 2021 recommendation, Class 1. References. 1. Buttle J.E. et al. Pathogenicity and virulence of Clostridioides difficile. Virulence. 2023, 14, 12150452. PMID, 364192222. https://pubmed.ncbi.nlm.nih.gov/364192222. doi 10.1080/2150559.4.2022.2150452. 2. Bezlotoxumab M. et al. Imaging Clostridioides difficile spore germination and germination proteins. Journal of Bacteriology. 2022, 204, 7E00210022. PMID, 357627766, https://pubmed.ncbi.nlm.nih.gov/357627766. DOI 10.1128/JB00210-22. 3. Lee C.D. et al. Genetic mechanisms governing sporulation initiation in Clostridioides difficile. Current opinion in microbiology. 2022, 66:32-38. PMID, 349332206, https://pubmed.ncbi.nlm.nih.gov/349332206. DOI 10.1016/J.MIB.2021.12.001. 4. Ariyoshi T. et al. Effect of Clostridium butyricum on gastrointestinal infections. Biomedicines. 2022, 10-2. PMID, 352036691, https://pubmed.ncbi.nlm.nih.gov/352036691. DOI 10.3390/Biomedicines 100204883. 5. Hassan M.K. et al. Role of glycogen metabolism in Clostridioides difficile virulence. M-Sphere. 2024, 9E00310024. PMID, 391897778, https://pubmed.ncbi.nlm.nih.gov/391897778. DOI 10.1128/MSphere.00310-24. 6. Ouyang Z et al. Cyclic diguanylate differentially regulates the expression of virulence factors and pathogenesis-related phenotypes in Clostridioides difficile. Microbiological Research. 2024, 286:127811. PMID, 38909416, https://pubmed.ncbi.nlm.nih.gov/38909416. DOI, 10.1016/j.micres.2024.127811. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.